Hi all. Sorry, we were having slight lobby issues. I'm just going to give it another minute so latecomers can file in. Okay, I think our number has stuff going up, so we will get started. Welcome everyone. My name's Cara McGuire. I work on adult social care tech policy. So I'm part of the DHSC's digital policy unit. And we work really closely with the DISC team who are delivering the social care interoperability infrastructure. Today is our second external stakeholder show and tell event. And at today's event, we are going to hopefully show off a bit more of what this infrastructure platform could potentially do. Um, if we skip forward to the agenda, please, Emily. Great. So we have quite a bit to get through. We're going to start with Chris, who is from the DIS team. He's going to outline some of the strategic context for the interoperability infrastructure. We also have Will from the DIS team who will talk about what we are trying to achieve. Then we have Mira and Sarah with us. They are both from Synonetics and they're part of our technical sort of delivery partner team. We're going to finish with a demo of the proof of concept. I personally am excited to get to that bit. I think that'll be really interesting. Then we'll finish with a Q&A. Now, given that we have quite a bit to get through, I'm going to ask people to put some questions in the Q&A or chat as we go along, rather than use hands, and then we will open up the Q&A for hands at the end, just to avoid us sort of getting sidetracked and not getting through all of the information. So unless there are any questions before we get started, I'm going to hand straight to Chris.
Thanks very much, Cara. Hi, everyone. My name is Chris Elkington. I'm Assistant Director within Digitising Social Care. So that's a part of a joint policy unit between Department of Health and Social Care and NHS England. Now, the care sector is extremely large. It's bigger and more complex than the National Health Service. And it contains an awful lot of work that's commissioned privately by citizens, also work that's commissioned by Department of Health and Social Care, commissioned by local authorities, by councils, so really complex. And when the government decides to get involved in an area like this, it has to make decisions about whether it's going to bring out regulation, whether it's going to nationalise whole services, whether it's going to start creating products to compete with what's already there. So these are all really huge, big questions. So the first step that we took over 5 years ago was like segmenting this and deciding what we were going to look at first. And because less than 30% of care homes had a digital social care record, it was mainly like a paper-based sector, so to speak. We decided to look at trying to increase the adoption of digital social care records. So as you can see on the slide here, over the past 3.5 years, we've laid the foundations and rolled out digital social care records to over 80% of care providers. So we did that by creating standards and assuring DSCR suppliers against those standards to create a list. We've done guidance, we've done reporting standards, we've rolled out a service called GP Connect to help these digital social care records be able to interoperate with health, with the NHS. And then we've done an awful lot of work on digital skills frameworks, training database, e-learning modules, things like that. So we did all this through co-design with the sector. We've decided not to compete with anybody. We've not put anybody out of business. We've not come in and tried to take control of people's systems, and we've done it at an absolute fraction of the cost and time that it would take to do things within the National Health Service. So this leads to what comes next. So Emily, could you please move on to the next slide? So while the government kind of grapples with this big decision of, well, what is the care sector and what does it want its whole role to be? The government has announced an independent review, the Casey Commission, to look into all these things, but it's announced three kind of big pillars. One is that it will roll out national standards for care technologies. I, for one, know when family members have care needs, it's really hard to know what is needed, what are my options, where do I go, what's safe, and what's different and better than all these other products. Joining up data for care, so when we speak to professionals on the ground, not knowing what's happening in health for care, not knowing what's happening in care for health, and different people just not being coordinated around the person is absolutely huge. And this continued push that all care providers will be fully digitised. So we're not going to present now and say that we've solved it all, but we're looking at one key aspect of that. We talked about rolling out digital social care records and the huge work that we've done then. And the next sensible thing would be to try and look at these three areas by going, how can we join up these digital social care records? So that helps with the fully digitised, helps with standardisation, and helps with bringing things together. So we've been working for the past 6 months on doing discovery into the areas and producing a proof of concept just to show that it is possible to do this work before we move into a big national build. And I'm going to hand over to my colleague Will, who will take us through a bit of the work that we've done so far.
Cool, thanks very much, Chris. So afternoon, everyone. My name's Will Hemingway. I'm the product lead on the social care interoperability piece. So taking that strategic context that Chris laid out, we've got a public ambition to join up health and care services with a focus specifically on adult social care. So as it stands, adult social care data sits in lots of separate non-interoperable systems. That makes it really hard for care providers and other services to share information easily and consistently. The result is duplication, it's inefficiency, and it's a very real risk to continuity of care. So our ambition is to change that, to join up information so people can access what they need, when they need it, supported by a solution designed for adult social care. We're building on what's already been delivered through the Digitising Social Care programme in previous years. Chris mentioned the widespread adoption of digital social care records. So this creates an actual opportunity to now join up information. There was also the mentioned development of a minimum operational data standard, which allows us to standardise that kind of information, and also the incorporation of things like GP Connect capabilities, which is kind of the beginning of that journey to connect with health. So as part of this ambition, it was agreed with ministers to take this forward through a discovery and illustrative proof of concept to test what social care interoperability infrastructure, which we're calling SCIP, could and should look like before making any decisions about a full-scale development. It's also really important to be clear about what SCIP will not be. SCIP is not about replacing digital social care records. It's not an analytics platform for providers, and it's not intended to be the single interface for reporting, AI, or care technology connections. And without further work on data storage or analytics, SCIP will also not store social care data. Next slide, please, Emily. So there are insights gathered over the previous years, which ultimately led us to kick off this particular piece of work. So considering the kind of current local context and what it looks like out there in the sector, there has been some progress in joining up health and social care data, but it's been inconsistent and incredibly hard to scale. Adult social care data is still held across around 24,000 different places, and suppliers are repeatedly being asked to connect into multiple health systems. In some areas, it's taken years just to put any data access in place between health and social care, and that level of effort both isn't sustainable, nor is it actually effectively replicable as well. So there's also a real cost as well associated with making these kind of connections. Suppliers have told us that integrating separately with lots of different systems is expensive, And also on the actual workforce side of things, providers have told us that staff spend a significant amount of time manually pulling information together and contacting different places. So this is all time and money that could be better spent on direct care. But see, there's an opportunity here. So by taking a national approach, we can put shared foundations in place that make interoperability easier, cheaper, and more secure, not just for today's needs, but for future priorities as well. So the hypotheses we've kind of kicked off here and that we're testing through this discovery phase is quite simple. If we create a single point of consolidation between health and adult social care, we can reduce the interoperability burden and improve the security of people's data. So I'll now pass over to our delivery partner colleagues who will explain what we've done today as of September and into detail on what that proof of concept looks like. So over to you.
Thank you very much, Will, and thank you, Emily, for the assistance. Afternoon, everyone. So you'll hear from a few of us this afternoon. I'll start off by recapping on what we've been doing for the past 6 months or so. So I assume some of you may be familiar with user-centered design and user research, but just for the avoidance of any doubt, I just wanted to start off by talking a little bit about what is actually a discovery and why we decided to approach it in this fashion. By focusing on upfront research with potential users of a future solution, we wanted to make sure that any design and technical decisions meet the needs of the people that this will be ultimately made available to. In practice, actually, what this really means is that we've been reviewing and learning from work and research that has already been done in the past, so as to use up all of the available learning and information that previous projects have gathered. We've also analysed what is working well and what isn't working so well with the current tech offering. So you've heard mentions of some of the solutions that currently capture social care data. And we spend time with a number of key stakeholder groups to understand their needs, challenges, and their experience in details. And how we did that was through a mixed method approach, which included some desktop research, a series of structured interviews. That just means interviews that had preset questionnaires that focused on the most specific parts of user experience that we wanted to learn about. We also carried out a number of in-context observations, so paying visits to social care providers to watch and observe how they currently operate. And also we did a series of unmoderated surveys. And as a result of all of this, we've landed on what was the scope of our research thus far. So if you could take us to the next slide. It had 3 main pillars: a user research pillar, a technical research pillar, and a governance research pillar. As you can see, they all had their own individual focus. On one hand, we wanted to understand who the potential users of a social care interoperability platform could be, their needs, their current ways of accessing and sharing data, and what use cases a product or a platform such as this one could facilitate in the future. From a technical research point of view, we focused very much on investigating and evaluating digital solutions and architectures, specifically for the Digitizing Social Care program, focusing on the list of assured DSCR suppliers. And from a governance point of view, the research aimed to answer a very simple but equally complex question around what is the potential legal basis to share data via SCIP, what controls will be needed, and is there any differentiation between health and care data, including any RBAC requirements. Now, having said all that, I really want to emphasize that this phase of the work is not about designing or actually delivering a solution. It has an exploratory nature, and it's all about gathering and analyzing information so as to determine the feasibility of what an alpha stage should and could focus on. So let me now take you through in a little bit more detail around our engagement and the user groups that we've been involving in our research so far. So this isn't weighted in any way or manner, so please, the closer you are to the center, it means absolutely nothing. It's just an easy visual representation of our approach to try and do a full 360 discovery spanning the care continuum. So in our first phase, which happened at the end of last year, we focused exclusively on engaging with social care providers and those delivering social care services alongside assured DSCR suppliers. And in the second phase of the work, we've been working with healthcare professionals across a range of services to try and understand the other side of the story when it comes to sharing data between the two settings. So in total, across 3 separate rounds of moderated interviews, we spoke to over 50 professionals across health and social care. The technical discussions that we had covered almost 50% of all assured DSCR suppliers, also including a number of national NHS service teams and share care provider platform providers. And in terms of our governance research, we had conversations with senior legal and IG stakeholders across NHS England and the Department of Health and Social Care. All of this ultimately has enabled us to gain a much clearer picture of the current as-is processes and helped us identify some key pain points that should inform any future decision making when it comes to skip. And we've been able to generate and refine a series of key themes, some of which I'll briefly talk through shortly. Just to give you a flavor of some of the questions that shaped our hypotheses during the phases of research so far, we set off by asking who actually needs to access and share health and care information and what is the legal basis for that need. What did the current end-to-end journey look like for someone sharing and accessing information in that fashion? Did they have any specific challenges or barriers that maybe were different between the different user groups? So that's why it was really important to us that from a social care provider point of view, we covered as many different types of settings as possible, including residential care, domiciliary care, supported living and extra care. We also, from a tech point of view, we wanted to understand the current capabilities within this landscape and whether DSCR providers themselves faced any specific pain points when it came to integrating with health APIs. So where did that all land us? As I mentioned, we wanted to arrive at the point where we had some very concrete use cases that we can focus on. And here they are. We distilled them into 4 based on the information and the research that we've carried out. And they are as follows. One very, very common and very prominent throughout the research was to do with transfers of care between providers, with research participants citing that they often experienced inconsistencies and had to deal with different blockers when it came to technical or commercial barriers. So a use case that we wanted to explore further in the second phase of the research was whether a shared platform could enable a seamless transfer of records between providers and in a way promotes standardization across DSCRs that would reduce some of the duplication and the admin burden on the individuals. We also landed on a use case centered around NHS number coverage and NHS number matching. We've heard time and time again how inconsistent use of NHS numbers across systems made it incredibly difficult for people to link and transfer care records reliably. So we wanted to ascertain whether a shared platform could facilitate a higher NHS number usage across records that would then enable some automated lookup and validation features and improve record matching that will again have a positive impact on reducing the manual effort required in data linkage. We also sort of fleshed out 2 further use cases that needed additional research, and those were centered around the interactions and the touch points between health and social care. So one of them was specifically around multi-agency information sharing, where care teams lack visibility of external agency interventions that may lead to missed care calls, poor coordination, and numerous manual workarounds being designed and implemented. And the other one focused on transfers of care between different settings, with a focus on the admissions, transfers, discharge as sort of the funnel that a particular person in receipt of care may find themselves going through. So both of those wanted to see whether shared platform could enable real-time updates and automated notifications that would again reduce the manual burden and also ensure that information is made available in a timely fashion. So I want to now take us through what each of those 3 pillars that I outlined have so far determined. And this is very much with all discoveries, this ultimately leaves us with many more questions to answer and many more sort of avenues to explore. So it's not meant to be a final state. It's only the beginning of a much, much longer research piece. So from a user research point of view, throughout this whole discovery, we've landed on some very key insights. For example, staff relying on manual workarounds, email chasing, and printing. If you go back a slide, please, I'm sorry. And printing reams of paper in order to obtain and share essential information. Equally, the absence of patient social care context information at the point of an admission could often result in avoidable discharge delays and late-stage planning complications. We've heard how fragmented systems place a burden on people and their families needing to retell their medical and social histories to different services and often having to advocate for themselves. And the flow of information often being a one-way street, resulting in late notifications to care providers, discharge information delays, and care packages not being updated in time. And I've chosen to include some very poignant quotes from some of our research participants. As you can see on the right-hand side, we had a domiciliary care manager speak about how they've got no way of knowing what's gone on until we find a discharge letter, or for example, a community nurse having to frequently turn up to empty homes to administer care, entirely unaware that that patient has been admitted to hospital. From a technical research point of view, we have a completely different set of insights, which look as follows. We reviewed the national digital services and the suppliers to see how current tools measure up to future needs. We also focused on testing how well today's tech would support real world data sharing, and sort of whether it would sort of enhance or be at the detriment of some of the pain points that we were hearing from actual users of systems. We found major gaps in standards compatibility and NHS number coverage, and also that providers need a simple and unified way to access information that the NHS holds. A connected model is definitely needed to provide a single front door to all health and care data. And the existing platforms already support key use cases, and they simply need targeted improvements. So this is very much a direction of travel whereby we would encourage to reuse and sort of build upon what already exists across the landscape. And ultimately for the information governance discovery, as I mentioned throughout our series of targeted conversations, which covered legal, policy, technical and operational domains, we explored the lawful basis for sharing data, including whether there is an implied consent and the GDPR provisions. We also assessed the variability in IT maturity, access models and roles across adult social care providers. We identified that DPIA, DSA and RBAC complexity and the public communication needs needed to be closely explored further. We were able to confirm the alignment of many of the use cases that I just took you through, matched existing legislation available, and that embedding privacy by design into these processes and user journeys was essential for any future development. So I appreciate this was a lot of information, a lot of content to go through, and of course there'll be an opportunity to go through it in more depth and for colleagues on the call to ask any follow-up questions. But as Cara mentioned right at the start, I think it would be really helpful for us to now have a view of that proof of concept, which would really bring to life how we've been able to take forward two of those use cases that focused on NHS number lookup and transfer between one DSCR supplier and another DSCR supplier. So at this point, I'm going to hand over to my colleague Sarah, who's going to tell us about that work, and we'll do the demonstration as well. Thank you.
Brilliant, thanks, Mira. Yeah, could you just go on? I think I have one slide before I'm going to steal the screen and show you the prototype. Yeah, so we've got the proof of concept, which I'm about to demo to you. These are all focusing on 2 of the 4 use cases that Mira has taken you through. So the other 2 use cases have been undergoing some further discovery, which is why we haven't got anything necessary to show you physically yet. But I will be taking you through the DSCR transfer. So this is where we're providing a way to transfer care records between providers. So we've heard that this is inefficient, inconsistent, and is often blocked by technical or commercial barriers. So what we're trying to do is we're trying to enable a seamless transfer of care records between these providers, promote some sort of standardization across suppliers, and reduce that manual duplication and improve that continuity of care. The other use case that I will show you is the NHS number lookup. So what we've heard is that there's been an inconsistent use of NHS numbers across systems, and it makes it really difficult to link and transfer care records reliably. So what we want to try and do is mandate that NHS number uses across care records, enable an automated lookup and validation for this to stop people trying to manually find that NHS number through bits of paper from what we've heard from our research. And yeah, again, just reduce that manual effort and errors in that data linkage. So what I will now do is I will steal the screen. Bear 1 second. So you've got that one there. So yeah, so what you're seeing here, this is the proof of concept that demonstrates the 2 of those use cases that I've just mentioned. So first of all, I'll show off the DSCR to DSCR transfer. So this is where a resident is moving between care providers, reducing that manual need for care teams to recreate records from scratch when someone arrives with an existing record elsewhere. And then secondly, that I'll demonstrate the NHS number lookup using demographic information that is stored in the DSCR to automatically retrieve an NHS number, which is reducing that need to search through paperwork. So here is this is the prototype, the proof of concept that we've created. So what this is doing is this is demonstrating the technical capability of transferring a service user record between DSCRs. So yeah, I want to just highlight that this is definitely a proof of concept, and what we're illustrating, we're using this to illustrate what's happening behind the scenes through the screens rather than showing you the code itself. And all data that you see on these screens here is entirely fictional, and they're not real patients at all. So yeah, the scenario that I want to take you through is around a service user called Amberly Jinen. So she's wanting to move from Rosebridge Residential Care Home, which is the DSCR that we're seeing here, to Willow Court. This could be due to increased care needs, so maybe Rosebridge can no longer meet her needs, or she has a desire to be closer to her family. So what we can see here is that Rosebridge has received a data transfer request from Willow Court Residential via the Skip Transfer API. So if I take a look at this, so here we can see the incoming request for Amberly's record. So this screen shows the requesting care provider, the individual who raised the request, and so that the user can then just inspect this request and make sure that that's what they're expecting. But in practice, both providers would already be aware of this transfer. So yeah, so they shouldn't be unexpected at this point. But anyway, they can go in and review that request. This provides a bit more detail, including the reason for request, and at this stage, the user can come and have a look to make sure that there's the right subject of care, the organisation is what they're expecting, and the details are all matching what they're hoping to hear. And at this point, the provider can then accept, reject, or request further clarification for this transfer. So in this scenario, I'm going to accept the request. And then what the next step in that process is, this will send a notification to Willow Court. So this is the care home that Amberly is heading towards. And then at this point here, Rosebridge, so the source provider, can now prepare that export, selecting which part of Amberly's record to share. So in this screen, we've included a core clinical data set to illustrate how a minimum data set could work. This has been based on the MODS, the minimal operational data set. Again, this might not be how it works in reality, but it's showing an example implementation. So the key point I want you to take away from this screen is that the providers can remain completely in control of what data is shared, and they're not required at all to send absolutely everything to the next care home. So what they can do here is you can select what information that you want. So in this example, I will select everything and then generate that export. So then what this happens next is that the system will then package that data, validate the record, and prepare it for transfer. So before actually sending that on to the next provider, I want to just quickly review through this. It's all okay. I can confirm that I'm absolutely happy with it, and then I'll send that export to Willow Court. So let me take you through what Willow Court will see once they receive that kind of transfer information. So we can see here that they've got Amberly Jinen's record ready to be imported. So we can click on import. So this is their DSCR. So here we can see another version of the screen that I just showed you, but this is now a view of all the data that is present in that export. So again, I want to highlight that this screen is just a representation of what this process could look like. In reality, each DSCR may implement this slightly differently. What I want to highlight on this screen is that the care provider can then pick and choose which data items to import. So this means that they are maintaining control over their local records. There's no obligation to import absolutely everything into their local record. So again, they can go through this screen, select the items that they want to import, and then they can import those selected items. So then the selected data, that will take a bit of time to move into the to Willow Court's DSCR, and then the data should appear automatically. So this will be the care plans, whatever information that they have highlighted on that screen, all their allergies, medications, that kind of thing. So this will remove that manual data entry, reduce that duplication of effort, and ideally improve that continuity of care. So the next use case I want to demonstrate is all around the NHS number lookup. So let me just grab this one here. So here we have a resident, Romy Applegate, who does not yet have an NHS number recorded on her DSCR record. So what we can do here is we can see that they do not have an NHS number. We can click look up NHS number, and This will open up a pop-up which will pull through the resident's information that is needed to perform that NHS lookup to the personal demographic service. So this includes their first name, their last name, sex at birth, date of birth, and postcode. So the user can sanity check that this information is correct before performing the search. So the search will then be performed. If a match is found, like in this example, the NHS number is returned with full traceability. This can then be added to the record, enabling access to their health information. So I want to show you what would happen if there wasn't an exact match found in the lookup. So here we have another test resident will do the same process. So we'll look up the NHS number, look at all the details here. But in this instance, there is no match has been found, or multiple partial matches exist. So the system will then return an error and will provide some information. Okay, this could be because there's an address mismatch, there's been a name misspelling, or there's an incomplete postcode, for example. So the user can then go back, refine the search, and hopefully that will then improve that match. So that's the end of the demonstration of the two use cases. So I wanted to highlight that this will demonstrate a repeatable, reliable way to retrieve NHS numbers without manual effort. It also shows how SCIP enables secure data sharing, consistent transfers, and alignment with MOD standards. So ultimately, this supports safer, more efficient care transitions, and it's about reducing the admin burden so staff can focus on care. So I'm not sure who I'm handing back to. I think, is it back to Chris?
No, it's back to me, Sarah. Sorry, I was having trouble finding my unmute button there. Okay, thanks all for a really helpful presentation. We have just a few questions in the chat, so I will go to those first and let others digest what they
Sorry,
found.
I think Cara, we've just got, if Emily could share again, I think we've just got a little bit of a sum up slide before we go into the Q&A, if that's all right.
Apologies, I'll let everyone
No, that's all right.
stir on their questions then.
Sorry, Emily, if we could go slide 16. There we go. Right, so sorry about that, Cara. So Sarah just gave a fantastic example of the proof of concept that we've built. We had a ministerial commitment that went out like a year ago that we would start work on this and we'd come up with the proof of concept by the end of the financial year. So, you know, we're really excited, really glad that we did a full GDS compliant discovery within that period, and we've come up with this proof of concept. So the questions are, what's next? So we've come up with this prototype. What we now need to do is move into alpha. So as much as that's illustrative, we've seen in the chat that DfE are doing some work on producing products that do the same type of things. Within health, there are different data transfer and lookup and user-facing products that do the same type of things. If we're going to build things, then there's loads of different, you know, commercial products and services and tools which could all be used to do it. So we've got to do this kind of like management by committee options analysis of exactly what are we going to do and who's going to build it and how. A little team of the people that you see on here aren't going to create the entire interoperability infrastructure between the whole of health and care. But we've now proven that it can be done and that there is a need for it, and we need to get into that scaling. So that'll move us to alpha. And then how we scale and how we go beyond that will take a very agile approach. So rather than spending, you know, 10 years trying to hook up all of the different use cases and all of health and care, what we want to do is be able to segment it, release products to do that, and then move on and build it. You know, first version of iPhone, very different versions of iPhones that you get now. If we go on to the next slide, please, Emily. So what we plan to do is have a roadmap, and apologies for getting very agile with people, but the idea being, rather than having this specification that was designed by somebody that had the idea right at the very start, we spend the 10 years, go off, produce something, then when you deploy it, it doesn't do what is actually needed. That we have this idea of a roadmap. You know, we've got a destination of where we want to get to, but there might be roadblocks, there might be diversions, we can move. So an indicative thing of how that might look is, first of all, we've talked about connecting care systems together. So I started this whole conversation with care is massive and care is very complex, and there are difficult areas and easier areas, and it's not. And Will outlined how the information isn't connected, isn't interoperable at the minute. So being able to hook those things up first is a kind of quick win. We've been working with the DSCRs. You've seen we've been able to come up with a proof of concept really quickly. And then because health is a very digitally mature sector, they have products that are able to push health information out. So we could adopt that and bring that into care as quite an easy next step. But then as we gather all care information together and we start to be able to pull that into one place and get agreements, from IG to be able to reuse it and do things, we can then get that care data over into health, and then we're starting to really tick off some of these big ticket interoperability items. But then on top of that, we know care sector, well, and the whole public sector is really stretched from finances and capacity perspective at the minute, and the huge advances in AI and products out there that can make people's lives easier. So deploying things like that, ambient voice technology and decision making is being used in the adult social care sector more than any other sector in the country. So all the other departments are looking to us to say, how are we going to regulate this? How are we going to make use of it? So doing those things, once we've got this infrastructure in place, we would have the ability to deploy these. And then number 5, again, we've got in the chat, we're working really closely with DFE, obviously Department of Work and Pensions, really closely tied to social care and housing and all of these different areas. So being able to hook up, we talked about the private sector, most of the adult social care work is actually commissioned by people and paid for by themselves and by their families. So being able to bring in those citizen apps and things as well. So this is what a roadmap might look like for future work. So as I said, can't solve everything for now, but this proof of concept in the area that we're looking at has the ability to scale to start to solve those really big problems that I talked about at the start. So that was everything. Thanks, Gavin. Now we can proceed into a Q&A if anybody has any questions.
Thanks, Chris. So I think actually building on what you've just said around working closely with DFE and others, Alison in the Q&A has flagged that the problems that we are seeing and trying to solve are very similar to those identified elsewhere in the NHS, and she asked if we'll be sharing the slides.
Yep, I think I can't remember, but I think there may be a plan to upload this onto YouTube so that people can view it afterwards. And we're trying to work as in the open as we can. We've been doing monthly show and tells. We'll continue to do that throughout the product, but we're going to be working as much in the open as we can. And it's, as somebody that's been in the organisation nearly 20 years, I think it's a crying shame that across wider NHS England and DHSC, the work isn't as well known as it is. So people that do know me will know I'll be doing my thing to get on as many big broadcasts and get things into newsletters as much as possible to show this, because I think we're taking a very user-centered approach to doing this. So the things that we're finding are very applicable to lots of other products and services out there.
And then probably building on what you just said about the user-centered approach, Sarah has asked about care staff in particular, so those working in care settings, how many of those have been part of the discovery phase? Will?
Yeah, I don't mind taking that one. We had it a little bit on the slides, but we've engaged with about 13 nursing and residential homes, 6 domiciliary care providers and 4 supported living, as well as 8 in primary and community healthcare. So in practice, what that meant was actually direct interviews with those individuals. So that's speaking about their particular barriers, difficulties, wants and needs in this particular sphere. So those were direct interviews, and then those were supplemented by kind of surveys with a broader set of individuals as well. So yeah, the user has been at the center of all of this discovery from the very beginning. Sarah, yeah, if you wanted to come in to expand on that.
I just want to add to that, we also did 2 in context observation sessions. So we went out into 2 care homes, and observed their issues and interviewed care staff directly in the care home as well.
Thanks both. I think that has exhausted the questions that we have in the chat. So
I
I
think
will
I've seen
open it up.
Sorry, Cara, I think I've seen one more just pop up literally just right now.
Excellent.
Around is the social care proof of concepts for a care home transfer logically the same as GP to GP process large record. Well, actually, do we have Rob on the call?
I am on the call. If it's me you're asking for.
Oh,
yeah,
sorry,
it's
two Robs. Sorry.
All right, I'll let the other Rob jump in then. Who's the other Rob?
Conceptually similar, yes. Obviously, they're not, technically the same. And is the answer to that briefly, I think.
But it's still stuff being collated and
Yes.
given sent from A to B.
Indeed, yes.
Yeah.
Yes.
Okay.
Yeah.
Because obviously in an ideal world, we haven't got there yet. The idea about 5 years ago in primary care, which hasn't happened, is that the data was going to be separated from the applications, so that to do a GP to GP transfer, you just basically change one bit of data. The GP practice is this, not that. But that's still a long way off. So it's still a big bundle from A to B.
Yeah.
And whether in social care, it's obviously no way near as mature as primary care, of whether it's even conceivable to separate the data from the application, which makes those transfers so much easier. But also, just very quickly, I don't know, a transfer is such a frequent thing that it's really high on the to-do list.
Well, I think it was tackled as part of this proof of concept work purely because it was raised a lot by end users. What we aim to what we set out to do with is just to demonstrate a way in which it could be achieved using a prototype platform. Now, anything that it's kind of been developed as in proof of concept doesn't mean that it'll ever see the light of day as live, as it were. As for whether providers would separate their data and like from the application, I think there are a couple of providers on this call who would be able to answer that. My feeling is no at this moment in time, however.
But if I could just if I could just join in and like immediately jump to the aid of the care sector, I think that some of the time, because the NHS has got so many people working in it and has so much money attached to it and kind of is the focus of everything, people come from a very health-centric way of doing it. So I'd take issue with primary care is more mature than the care sector. When you look at a lot of these DSCR suppliers, everything is mobile first. Everything is looks very modern and is working in a far more modern way than having worked in primary care for many years. There are lots of issues there. I think one of the things that it takes us back to these big strategic things that we can't answer now, but the care sector, because it isn't health, so these things aren't medical devices. The amount of hoops you have to jump through in order to transfer data, to access data and do things within health is very different to what you have to do in care. And we need to make decisions about whether we're going to roll out health way of doing things over care, or whether care can have something different. So for care to be able to send data to each other, they might not have to go through as many hoops to be able to do it. And because there aren't lots of big national systems already in place, there is the potential to take those decisions about separating out data layers and things. As Rob said, that's a huge, massive decision that would, rock the entire sector, and it's unlikely we're going to be, doing something like that. But it just shows the kind of greenfield nature of, these suppliers that are working with us are so able to move and so willing to move, that the potential for us to make big changes that do really have an impact on citizens is huge here. So yeah, there's lots of ability to do things. But yeah, I just wanted to jump into that kind of, is it just GP to GP and could we use that type of a thing? Because this is the care sector, it's a bit wider than we could just use health in order to do it.
Thanks, Chris. I think we have a question from John first and one from Tom in the chat.
Hi all, I'm really sorry I've come to meeting very, very late. When we're talking about data being transferred, what sort of data are we talking? We're talking about sort of care plans, this is about me plans, EMARs, risk assessments. What sort of data, is that the sort of data we're talking about?
For the proof of concept, a very selected data set was chosen as the transfer. So I say proof of concept because it's not set in stone. However, the data types that were used in the proof of concept included some of the types you've listed there: about me, risk, wish, care plan, and so on. The way in which the platform's been created is such that it uses the minimum operational data standard as its foundation. So about me, care plan, etc. Those data types are all modelled around what's in the MODS data dictionary.
Sorry, a couple more questions. Where did you do this demonstration, this test of?
We haven't actually we haven't finished. It's due to be completed on about 31st of March.
Oh, okay.
The internal, I mean, I'll hand back to Chris and Will to say, because I'm not too sure the politics of sharing all this. But
no. Well, I think there's a bigger conversation that might need to be having with the guys from NHS England here, because we have a platform that we're already doing this, where we've got care providers to GPs to acute hospitals back to GPs, all in real time now, with over 100 care homes linked straight into a hospital and several GP services online that we can share directly to. So I think there's been a miscommunication here somewhere, or we've missed a trick.
Yeah, I think rather than missing a trick or anything. So there are lots of shared care record systems, 42 shared care records systems that cover it, and lots of other systems.
Yeah, this isn't a shared care record. This is a social care driven thing where we've got 100 care homes linked directly into an acute and then to GPs, so we can transfer the data in between ourselves in real time. Maybe we just need to have a conversation and map that for you.
Yeah, I think that, I didn't mean it was a shared care record system, but there are lots of other, as Will outlined at the start, which I think you said you
which I probably missed.
Yeah, no, it's fine. But I think all of these different systems that have been created over the past decade have had quite slow rollout across social care. So 24,000 social care sites. And is hooked into 100 of them, hooked into that. What this work is about trying to supercharge those existing systems. So we're not trying to replicate front ends, we're not trying to replicate systems, but the system that you talked about, if you were to plug that into something that had the reach of the entire social care sector, that's going to really supercharge it and move it about. So this is about underlying infrastructure that enables others, rather than saying we want to come along, we want to take existing systems that lots of people have spent money on and doing it. What we found is we've done discovery, lots of shared care record systems. I don't mean shared care records isn't the actual shared care records, but shared care record systems have spent a really long time and a lot of money trying to roll out piecemeal site by site by site. So is there something we can do to basically supercharge all of that? So that's the intention, rather than let's replace them.
Do you want to email me and then we can have a proper chat offline?
Yeah, of course, John.
Yeah.
Would you mind just putting either I can put my email address in if you don't mind putting your email address in the chat, or I can put mine.
I'll pop it in the chat now. Yeah.
All right. Cheers, John. Thanks.
Great. So if we move to Tom's question in the chat, I'm conscious we have 5 minutes left and a few questions, so we'll try to move through these quickly. Tom's asked, are we going into alpha with a hypothesis about whether this is a user-facing application in its own right, a set of services for existing digital suppliers to use, and a pattern for them to implement, or something else completely?
I can say I think I just reiterate what was said at the start with that. So there is no, our brief is not to build a user-facing application. Therefore, I guess anything that goes into alpha would effectively be what was the question? Services or API endpoints, effectively like a platform in essence.
Great, thanks, Rob. Then Alexandros has asked if whether the CQC has been involved in the discovery phase at all.
I would, yeah, Mira. I think that's probably yes. Yeah.
I mean, can I jump in because I typed that question right? My gut feeling is that providers will be very skeptical to simply transfer full care plans at the point of admission. And I'm saying this because I used to manage services, right? So it's standard practice that you will do your new risk assessments and everything once a new admission comes in, because you want to ensure person-centered care. You want to ensure that you're meeting the needs of the client, the resident, whatever terminology you choose to use. So if I didn't pick it up during the conversation, during the presentation. So if CQC is not aware of this, that the data can be transferred at the push of a button, and I'm a registered manager, the platform is up and running, I transfer data, and then an inspection comes in and they say, well, when did you create all these risk assessments and care plans? And I have to explain that to the CQC, it will probably look bad. And my other point in the question is, DSCR suppliers, right? We started off with an assured list that initially had 8, then went to 13, then to 11, now to 18. So the market shifts and moves all the time, and they're competing with each other, and they're going to start competing with features, and also there's going to be consolidation in the market. So they move quickly because they're for-profit companies, and by their nature, they tend to sort of chase the money, so to speak. Public sector is a bit more slower to move. So how can we ensure that Skip remains agile and that flexible enough to meet the needs now and in the future as things develop?
Yeah,
these are my questions / comments.
No. Thanks, Alex. So I think for the first one, well, CQC are aware of the work that we'll be doing as a DISC program. We're and across DHSC, we're very hooked up with them. I think there's probably a difference between this proof of concept that we've shown to demonstrate capabilities, and then what's going to be built in and what will be the first live feature. I think transferring an entire record, somebody mentioned somewhere, how much does that happen? How much do people actually use care homes? It's not the biggest thing that happens every 2 minutes, but it was selected as the use case for the proof of concept because being able to transfer an entire record looks very impressive and shows out some of the features that would be able to do the most. But that doesn't necessarily mean that's the first thing that you would go live with and that we would use in our beta product that we deploy to the system. I think as we've gone through it, the NHS number sourcing and the NHS number lookup looks to have much more impact. So I think there's a difference between the use cases that we showed as priority out of the discovery to be able to produce the proof of concept and what our use cases would be. And then that links into your second question of how do we make sure we remain agile and that we're able to move at pace. And that is that that use case methodology. So having different use cases and being able to prioritize them differently and tackle them in order. If the government manages to find a lot of money 1 year and there's a lot of money for development, we can do many more use cases in parallel than at times of austerity where they're shutting other programs and services, and then we only need to move other things. So that kind of speed up, slow down, work in different priorities will definitely be agile. So I can see a vision where the service can go live to be able to add value with NHS number knockups, and then different areas, different functionality will be added, over the course of time, rather than waiting in that waterfall way to we think we've built every single use case, addressed it, and then gone live. Because hopefully that's the type of thing you're asking about, Alex.
Yeah. Can I have a follow-up question, being very mindful of time? The prototype we were shown, is it a functional Figma, or is it actually making API calls to some version of the Skip, pulling data, pushing data, and tapping an API call into NHS numbers?
So the thing that we showed you was a Figma, because we thought about demonstrating, lots of JSON code going backwards and forwards, and it's probably not the biggest thing that's going to appreciate the algorithm on YouTube. So we have developed the kind of the prototype in the background. It's still, using test data to go from test environment to test environment. So it's not a functional live thing that we've built at scale, and we need to decide what we build it out of, etc., etc. So two different things. You saw the Figma, but we've developed the proof of concept.
Great, thank you for that. Thank you for the clarification, Chris.
Thanks all. So there's one question we haven't got to in the Q&A, and it's quite a big strategic question from Ben, if he's still here, which is around how what integrated neighbourhood models of health and care, so the 10-year health plan, ambitions around those mean for digitising social care. Chris, if you want to give a sort of very brief version of an answer, that's something maybe you could come back to in the next one of these external stakeholder events.
Yeah, I think it's probably one for next stick. So lots. It's a very short answer. We're working with neighbourhood teams as they emerge and as they move out. So the whole closure of NHS England, the merger with DHSC, and changing to different priority areas, neighbourhood's going to be one of the big ones, and we're going to be working really closely with them. So we're working with programmes like the single patient record, and we're working with neighbourhood to make sure that things are done in a health and care way instead of just done in health. So yeah, there'll be lots there, but not something I can cover kind of in 30 seconds.
Yeah, thanks. So with that, I will bring us to a close. Thank you all for your time today. Sorry for running over slightly, but hopefully that's a sign that people found this useful. We will send around the slides and the link to YouTube, assuming all of that works. And then we'll be in touch with the date for our next show and tell. But thank you all for your time today.
Thank you. Thanks, Cara, for chairing, and Emily for sharing the slides. Thank you. Cheers. Bye.
Thanks, everyone.